Okay. So I think we've got everybody on. I think everything's going.
Great.
So Amanda, I put you on the screen. Everybody's looking at your face right now, which is awesome. It's good to see you.
Sure. All right, you ready for me to introduce, or do you want me to wait to give it a minute or two?
Go ahead.
Okay, wonderful. Well, guys, welcome to Hill Country's Brown Bag. We are so glad to have all of you here. Today, I get to introduce our brilliant speaker. I'm on maternity leave, so that's why I'm in my bathroom. But today's brilliant speaker is Paige Cryer. She is a dear friend of mine. She got her undergrad from Texas A&M University. She got her master's degree in biblical counseling at Dallas Theological Seminary, DTS, their Houston campus. She's an LPC in the Houston area. She's, like I said, she's brilliant. She was my play therapy guru when I first started my practice. But since Paige has expanded her practice, she does EMDR. She works with a little bit of everybody, college students, young adults, parents of young kiddos, new mothers, you name it, she does it. She's awesome. Like I said, she's expanded into EMDR, and she specializes in working with perinatal and maternal mental health. So that is what we have asked her to speak on today. I'm so excited to learn from her. So Paige, I will turn it over to you. Hopefully the technology lets us see your screen, but I'll turn it over to you.
Thank you, Amanda, for the kind introduction. Good to see your face, friend.
Oh.
I am going to start. Let's see if I can get my screen sharing worked out. Okay. I think, can y'all see my screen?
It looks like it's working.
Okay, awesome. Great. Let me just make sure. Let me make sure it's going to keep up in real time too when I click on the next one. Fabulous. Okay. Yay for technology working out. I'm so honored to be here today to get to talk about perinatal and maternal mental health. Thank you for the super kind introduction, Amanda. That was super sweet of you to speak so highly of me. But I am really honored to be here and feel privileged to be trusted with an hour or so of y'all's valuable time. I know y'all could be seeing clients or just relaxing and enjoying lunch, but instead you're going to listen to me talk. So I hope that this is helpful for y'all. I'm hoping to have enough time to open it up for questions at the end. So we will see, and maybe even at a halfway point midway through. So we will see if that works out, but if not, y'all are welcome to email me any questions or comments at the end. So just a little bit about myself. Amanda did a great job introducing me. I'll briefly go through this, and she said most of the things. I am an LPC in Houston. I'm trained in EMDR and child-centered play therapy, and I'm working towards my certification in perinatal mental health through Postpartum Support International. I've had a great several trainings with them and just need to sit down and take my test, which will come hopefully very soon. A little bit about me personally and why this topic is really important to me, not just professionally, but personally. I am also a wife who just celebrated 10 years with my husband. I'm the mother of a 4-year-old daughter, Olivia, who's wonderful, a baby boy in heaven, as well as a baby girl on the way. We're due in September. So a personal touch with a lot of different things here. I'm also a NICU mama with my daughter. She was in NICU for about 2 weeks, and a secondary infertility fighter, which has been quite a journey for me. So as y'all can see, this topic is not only professionally important to me, but also personally really has lit a fire to support moms and dads and new parents of all kinds on their journey to becoming parents. So today we're going to talk a little bit about perinatal mental health starting off, as well as supporting women postpartum. First, we're going to kind of transition a little bit into speaking on entering motherhood. It's going to be kind of our kicking off point. So expectations might not always match reality. A lot of people will give the cliches of like, you must love being a mom, or baby's so precious, I bet you can't put them down. And sometimes many women do feel that excitement, but also fear whenever they're pregnant, or joy and sadness whenever they're postpartum. The transition into motherhood can be shocking, especially if we aren't encouraged to admit whenever it gets really, really hard. There are so many positive expectations surrounding conception and pregnancy and the postpartum period that many women feel they shouldn't feel disconnected with themselves or with their baby during this time. Oftentimes women hold the role of mother, and the idea of motherhood is sacred. And when their reality of their own experience doesn't really match up with their expectations, they can often blame themselves. This is why women need support, especially during this time. PMADs, or perinatal mood and anxiety disorders, which we'll talk about a little bit later, they don't discriminate. It's not a mom's fault if they're feeling like they're not themselves, or if they're struggling to connect with their baby. Struggling with a PMAD does not make you or any woman a bad mom. It means that she's a mom in need of care and support. Like adolescence, this is a really transitionary period, not just physically transitioning into motherhood or transitioning into the healing of giving birth, but also the hormone shifts that you're going through, the new relationship with your body. It can be a really awkward phase, a lot of emotional shifts, a lot of chemical shifts in the brain that actually really mirror adolescence. So there's kind of this nickname of matrescence that's given to this phase that I find is really reassuring when I talk with new moms about that, of like, hey, we're going to be kind to ourselves, just like we can look back and be kind to our adolescent self and all the strange quirks they had and hard emotional moments. We are going to think of ourselves kindly and fondly in this moment. So yeah, in this period, it's almost like going through puberty all over again. Your hormones go nuts, your hair and skin don't behave the way that you'd like, and you develop a new relationship with your body that really kind of seems to have a mind of its own. So yeah, really the only difference is that everyone understands that adolescence is an awkward phase, but during matrescence, people expect you to be happy and joyful. And yeah, while you kind of feel like you're losing control over the way that you look and feel. Yeah, a lot of these emotion shifts can be explained, like I said, with chemical shifts in the brain as well as hormonal shifts too. So what is kind of the blanket term perinatal mental health? So perinatal mental health refers to the psychological well-being of mothers from the point of conception through the first year of the life of the child, so post-childbirth. So this is not just something that, oh, it's only the first 2 months or 3 months and kind of what's nicknamed the fourth trimester. This is something that lasts from the point of conception and pregnancy all the way through the baby's year marker. Many people can often think of the term baby blues whenever they hear about perinatal mental health. Yet the concerns can really range from a lot more than that. They can range from mood disorders like depression and anxiety to even more severe conditions such as postpartum psychosis, which we'll kind of go over a bit in the next slide. Even though it's not often talked about, postpartum mood and anxiety disorders are the most common complications following childbirth, with about 15 to 20% of women experiencing symptoms. Despite that staggering statistic, many women suffering with PMADs feel alone and feel shame about it and don't really want to bring it up to providers. So kind of the difference between baby blues and an actual PMAD, which we'll talk about in the next slide. Baby blues should really only last the first 2 weeks whenever your body is adjusting from the dramatic hormone drop that it's experiencing. I read something the other day that said it's like as if you were to take like 30 birth control pills for a month, straight, like 30 each day, and then all of a sudden you stop taking them. That's the equivalent of the dramatic shift that women go through just hormonally after giving birth. But if symptoms persist outside of that 2-week time frame, then we're going to consider PMADs and looking into that. So perinatal mood and anxiety disorders is a commonly used term to refer to mental health disorders experienced during pregnancy, after having a new baby, adopting, or experiencing pregnancy or infant loss. Postpartum depression is often used as kind of an umbrella term and really was something that it's not necessarily an outdated term, but it's just one subset of PMADs. But I think just because it's most widely known, most people will refer to any kind of struggle postpartum mood-wise as postpartum depression. So you can kind of think of it as an umbrella term. A high number of people begin struggling with PMADs actually during pregnancy. In the US, 1 in 5 pregnant women, pregnant or postpartum women, are diagnosed with a mood or anxiety disorder during the perinatal period. And also 1 in 8 women report symptoms of depression after giving birth. So PMADs can include anxiety, which can also kind of encompass postpartum rage. So feeling like, the baby's crying and you're just fuming mad about it. Or you can notice like a client might be come in talking about how they just feel on edge all the time, or like they're slamming doors or just cannot get it together whenever the baby's crying. That's kind of looking into a more postpartum rage category, screaming at partners, screaming at babies, things like that. Bipolar disorder can also develop as a PMAD. Psychosis, which this is an emergency situation. That's like I've heard from just on this topic in general, people will sometimes that will sound more like a client is coming in and saying like, I just am hearing this voice that's telling me I need to hurt my baby, or I am seeing figures, right? Like the typical signs of psychosis, it will just be oftentimes kind of closely related to the baby or related to what the mom is going through. And that's an emergency situation, just like any psychosis situation. We're not going to wait around and see if something bad happens from that. That's something that a client needs to be placed in intensive care right away. And then there's also kind of the classic postpartum depression, as well as OCD can develop postpartum. Intrusive thoughts overall can just be really common postpartum. And I'll kind of go on a little bit of a soapbox on that in just a second, as well as PTSD, especially if there was a traumatic birth experience, a traumatic pregnancy experience, PTSD can develop. So kind of my soapbox on intrusive thoughts, they can really ramp up in the postpartum period. I think the statistic is like 99% of people report experiencing intrusive thoughts at some point in their life. And I swear, I think the other 1% just didn't understand the question properly or something, because it feels like most of us kind of have that experience of like, oh, what if I were to just drive my car off the road right now? Or what if I just were to, all of a sudden yell out this curse word in the middle of church, right? Like we might not consistently struggle with that, but that can be something that certainly comes up in the perinatal and postpartum period. So I like to explain this to moms whenever they're, because the most common ones that I'll hear is like, I was walking down the stairs and I just got this intrusive like vision of my baby tumbling down the stairs, or I was cutting up vegetables or fruit in the kitchen and just imagined the knife going into my baby, right? Some like pretty disturbing things. Now, the way to kind of differentiate intrusive thought from psychosis, which I'm sure already know, in an intrusive thought, it's really disturbing to the client. They don't want to feel that experience. They don't want to or plan to act on it. Whereas in psychosis, it's more likely that the client feels the like need or urge, not necessarily want, but the need or the urge to act on that. So I like to tell moms, like historically and biologically, this is protective. I mean, if you imagine that you're going to drop your baby walking down the stairs, you're going to hold your baby a little bit tighter next time that you're walking down the stairs. That's not a negative thing. That's not bad. That's not clinically significant in any way. Now, when it becomes a problem, and when we're looking more at OCD territory, is whenever women are avoiding walking down the stairs altogether with their baby because they're so fearful that they're going to drop them. We start to see those compulsions coming along with the obsessive thoughts or intrusive thoughts. Or if they're making their spouse or their partner or whoever else hold the baby to walk downstairs and they're walking beside them. So that's when we want to kind of scan for, okay, we might need to do some exposure work around this instead of just treating this as an intrusive thought and something that we don't really give a ton of weight to. I also like to explain to new moms that like cave women, I mean, if we go way back historically and how we're biologically wired, cave women needed anxiety to stay alert to the dangers all around them. Now we're not fighting off like a saber-toothed tiger every day to keep our babies safe. But those danger signals, like we know, fight, flight response are still biologically wired in us to attune to dangers. So we want to kind of make sure that that's something that mom knows is really common and is not something we need to be upset with ourselves about, even as disturbing as it can be. But it's something that we can talk openly about without feeling like there's a stigma around it, or that mom is going to get in trouble or get baby taken away because they're having these strange intrusive thoughts. It really is about trying to protect your child. There are a lot of screenings there are a few screenings that are decent in this period. During the perinatal period, PMAD education and screenings are conducted as part of routine prenatal and postpartum visits. However, in the US, 1 in 5 women were not asked about depression during a prenatal visit, and over half of pregnant women with depression were never tested. So it's something that does, I think, not by anyone's fault, but just obstetrics in general and gynecology is, they're jam-packed, and it's hard for, especially if a client doesn't feel comfortable, or in their case, a patient doesn't feel comfortable opening up to their practitioner. They might not feel comfortable answering honestly on that questionnaire. Screening tools are a start, but more conversations and questions need to be asked around does the mother feel comfortable to answer honestly? Is the mother afraid to answer honestly? A lot of times I will hear the mom be fearful that the baby will be taken away if they answer honestly about what's going on for them mood wise in that time. Also, a big miss is paternal mental health. How's the father doing? Is he struggling too? Because they can also struggle with PMADs after a delivery. So you want to kind of scan as far as your own clients go. If you have a client who you feel is at risk of developing PMAD, you want to scan for these kind of risks. Any like childhood ACE factors, of course, we're going to look into and be curious about as far as what this client's trauma history was from childhood. Any previous anxiety or mood disorder is going to make someone more likely to develop PMAD. Complications in pregnancy, birth, or with breastfeeding, especially if they feel really like called or married to the idea of breastfeeding, or a certain birth plan could be really hard. A NICU stay is going to also increase your chances or increase a client's chances. Any birth trauma, a preterm labor, so prior to 37 weeks and delivery, is going to also be a risk factor. Of course, then we've got socioeconomic issues. Of course, if it's an unplanned pregnancy, those things could also lead to a potential for developing a PMAD. Thyroid imbalances, stress, relational, financial, and occupational. A mother of multiples, my goodness bless them, I cannot imagine. A history of PMDD, so premenstrual dysphoric disorder, can also be a risk factor for developing a PMADs. Inadequate social support, and infertility and complications with conceiving. So some treatment options, as we know, psychotherapy, obviously number one on there, but there is hope for any mom who's struggling with a postpartum mood and anxiety disorder, and many forms of treatment are available. Treatment should be tailored to each mom's specific situation and the needs and their needs, but it often can consist of things like psychoeducation, psychotherapy, medication, sleep hygiene support, nutritional support, exercise, social support. I really encourage each of y'all, if you're working with a mom, especially shortly after delivering, of course, just like with any client, we want to think of hierarchy of needs, right? We cannot expect this mom to be deep diving into past trauma if they are sleeping 2 hours a night at most. We need to really build from the bottom up as far as their physiological needs first, safety needs, and then moving on up into self-actualization and doing some more intensive work around what their triggers are. So just keeping that in mind. We don't want to, I don't want to say not expect much of a mom postpartum, but we don't want to have our expectations that they're going to be able to come in and do EMDR on their birth trauma experience 2 months postpartum if their baby is still not sleeping through the night, and if they're in pain every day because breastfeeding isn't going how they wanted, or if they're just really out of sorts mood-wise. Some additional supports that can be really great for mom are listed below. Many people say it takes a village to raise a child, but it also takes a village to raise a mother. The adjustment to motherhood is dramatic and drastic and life-changing, and many women are doing it alone, away from their support systems, especially if you don't live near family, or if you're estranged from family for any reason. In addition to the treatments that were listed previously, moms can benefit from supports like lactation support. La Leche League is a great resource there. Chiropractic care can also be really helpful postpartum. I know, certain people have certain beliefs about chiropractic care, but it's definitely worth considering if you have a client who's open to it. Sleep support, there are great options, like Taking Care of Babies is a great online resource. There's a lot of other books centered around sleep support. Night nurses are also a huge blessing if a client can afford that. Pelvic floor therapy can be great, especially if a client is experiencing pain and sex and the aftermath of a delivery, or just any kind of dysfunction whenever they're trying to use the restroom, or discomfort there. Postpartum doulas are also just fabulous human beings. So I would encourage any mom who can afford that support to get that, as well as grocery delivery. It sounds super simple, but Instacart, if a mom can afford that, or even getting a meal train set up, can be super helpful, so that that's not one more thing mom has to take on in the immediacy of delivering. So as far as practitioners, I would encourage any clinician to start early with their client. While many women begin treatment for PMADs after experiencing symptoms, it's also possible to begin building a support system prior to giving birth. If you believe a client is at risk of experiencing a PMAD, it can be helpful to collaborate with your client to create a postpartum plan in addition to a birth plan. Postpartum plans encompass multiple modalities of support to help prepare mothers to navigate the disorienting early weeks of the postpartum period. When well-supported, mothers come through the postpartum period feeling more connected to themselves and their baby, which is huge as far as we know bonding and attachment, but also just feeling good about themselves and this new role that they play. A postpartum support plan can include like meal planning and prep. So maybe you and client are even looking up recipes that they can freeze in their freezer to throw in a crock pot for the first like 3 weeks of baby being around, or after the meal train is stopped, right? Those things are great and they often last, the first month or so, but maybe having some frozen meals prepped and ready even after that. A sleep rotation schedule with their partner, coming up with like, okay, I'm gonna sleep the ideal is that each partner would get about 5 hours of sleep, at least a 5-hour stretch each night, if possible, which I know is not always possible, especially in those early days, but a sleep rotation schedule with a partner so that, maybe dad is better off in the early hours of the morning and mom is starting to feel, it seems like that like 3 a.m. to 5 a.m. time frame gets really, really lonely and scary for new moms. So maybe dad can take that shift instead of mom, and mom can be on duty from 9 p.m. until 1 a.m. and then dad can wake up and jump in before he potentially heads off to work if he doesn't have a paternity leave, or if he does have extended paternity leave, maybe we rotate every other night who is on duty with baby and who's getting a solid like 7 hours of sleep. So a lot of flexibility there depending on the client's scenario. We also want to look at recruiting the helpers and what they would be best suited for. Maybe client does not have the best relationship with their mom, and so mom would best be a help in like delivering groceries to them or coming over and doing laundry, but maybe mom is not best suited to be there helping client in the middle of the night if that's a triggering point for client, or maybe mother-in-law is super helpful at certain things, or not super helpful in other ways and might give input client does not necessarily want. So kind of really tailoring, bringing in your resources, pooling your people, but figuring out what they could be best supported for, and that's crucial to do beforehand instead of in the aftermath when you're kind of just scrounging for help. Sometimes even like a wash and fold laundry service could be really helpful for the first 2 or 3 weeks, if not longer. Like we said, grocery delivery, a postpartum doula, or a night nurse can all be really great things to kind of talk through with the client if they've got the ability to pay for things like that. So just some kind of sources on that first part of the presentation, but I want to kind of move into next the perinatal loss. I want to kind of talk through that too. All of that we talked about previously, as hard as it is, that's if pregnancy and delivery go, as planned, right? But what about holding space for when it doesn't? And when things don't go well and you're sitting across from a client who's really, really struggling. So first off, some kind of definitions and statistics of perinatal loss would include infertility, which affects 1 in 8 couples, miscarriage, which affects 1 in 4 couples, stillbirth, 1 in 160 births, infant loss, 1 in 185 live births, abortion, 1 in 4 females, termination for medical reasons is also included in this list, as well as pregnancy after loss. So a large population is impacted by pregnancy loss and perinatal loss, but it really is rarely discussed openly. So we'll start off with infertility. Infertility is a complex and complicated grief. There are a lot of different potential losses there, and it's something that really is feels stigmatized and isn't often discussed. I mean, it kind of can start to feel like this loss of hopes and dreams and expectations, almost like you've lost the baby that you're dreaming of every single month, or you've lost the dream of becoming a parent altogether. Losses related to treatment can impact physical appearance. A lot of the medications that you can be on can have really dramatic physical and mood impacts that come with them. It can have health, career, and impacts as well, and it can really affect your ability to engage fully and be present in life socially and emotionally. You kind of feel like there's always this looming thing in the background that you have to attend to. And then there's also, of course, pregnancy loss, especially recurrent pregnancy loss that can sometimes happen in infertility spaces, as well as the loss of eggs and embryos if someone is going the IVF route. Talking about something that it sounded like from when I kind of pulled a little bit of when I reached out to Stacy asking some questions that this is something that can come up often in y'all's practice. So miscarriage, which is defined as pregnancy loss before 20 weeks gestation. This can often be, there can also be a subset of this called chemical pregnancy, which is a loss of pregnancy before 5 weeks gestation, which I think the term chemical pregnancy, and we'll talk about some other triggering terms in this arena, but chemical pregnancy can feel really invalidating to some women. So something to be careful of. I think OBs will kind of throw out that term, but I like to really sit with a client and say, hey, that's still, whether that was a week of hope or, 5 weeks of hope or 2 days of hope, that was still hope and expectation that was built up. And we're still going to be able to mourn the life that baby would have had and be able to grieve that. And yeah, grief response is really dependent on the individual, often physically and emotionally traumatic, with common experiences of feeling isolation and invalidation. Another term here is a missed miscarriage that you might hear a client mention, or a client might say that their provider called it that and they're not sure what that means. That just means that the baby's died or not developed, but has not been actually physically miscarried. So often there's not really a sign that anything was wrong, and the news can come as a really complete shock. And it actually can take up to 3 to 4 weeks for the body to actually start producing signs of a miscarriage when this goes on. It's like the body just doesn't quite register what's happening. Stillbirth is also in this category, which is pregnancy lost after 20 weeks gestation. This grief is more similar to the grief of infant loss as opposed to miscarriage. The mother still has to go through oftentimes the process of actually delivering the baby, which can be long-term healing in some ways, but really, really traumatic in the moment. A third of stillbirths are unexplained statistically, but there are still a lot of reasons why this can happen. Issues with the placenta, the umbilical cord, a birth defect or chromosomal defect, infection, high blood pressure, environmental factors. There's a lot that can go into leading to a stillbirth. Infant loss, which is really just an ultimate violation in the trust of the rules of life and how things should go. There are often major medical complications that lead to this. NICU, obviously you'll see infant loss in NICU often. SIDS, which everyone's kind of familiar with, sudden infant death syndrome. Then there's also sudden unexpected infant death, which can include, it's kind of an umbrella term that includes SIDS, but also can include all of the factors listed too, like accidental suffocation while sleeping or other deaths from unknown causes or environmental factors going on around them. There is also this category of termination for medical reasons. This is usually due to concerns about fetal viability or disability. Chromosomal and genetic abnormalities are included in this list. Structural abnormalities, fetal reduction, which could be if if a mother is expecting triplets, but they know based on the mother's just anatomy, she's not going to be able to carry that many babies, and it's going to be a risk to all the babies or to the mother. That might be where a client might choose, or a practitioner might choose to reduce the amount of fetuses in utero. Really, really hard decision. I cannot imagine. It's occasionally due to the ability of the mother to be able to survive. That's not the most likely scenario, but does happen occasionally. And it's what's tricky is, it is biologically an abortion, but emotionally is much more similar to a miscarriage or a stillbirth. I actually had a client who had a termination for medical reasons. Horrible situation happened, and this was right around when all the abortion laws were changed in Texas. It was a while back, several years ago, but the client had a genetic abnormality that was fatal to the baby, but the baby still had a heartbeat. They around 20 weeks, and because the baby still had a heartbeat, even though there was zero chance of survival, organs weren't connected or attached how they were supposed to, there was no way that the baby would survive. They had to actually go out of state in order to obtain termination for medical reasons because of the new laws that were passed. Super traumatic for her, absolutely devastating to end a wanted pregnancy. And so she came in actually right after that to begin processing what all happened. We had some beautiful EMDR processing around it, but just a really painful experience as is. And then the way that the laws are currently really added another layer of trauma for her, and can for other clients, especially if a fetal heartbeat is still detected. So just something to keep in mind. just we'll talk briefly about abortion. Grief can still be present even if an individual chooses abortion. I have walked with a couple clients through this decision, and it is very, very challenging. Yeah, it's just, a devastating thing to have to sit with a client through. So you have to monitor your own responses and reactions as well. So not only is there, the option of abortion, kind of the like classic, what we think of when we think of abortion. Abortion is actually used in a lot of medical language, which can be really triggering. So we want to be aware of the language that doctors might use that can be confusing to a client, and prepare the client for that verbiage if you are sitting with them ahead of time and you know that they're miscarrying, or if they reach out to you, or if they come in saying, I don't know why this was on my paperwork, but this was just devastating to hear. So some of those terms can be spontaneous abortion, which is a miscarriage. Abortion is just kind of a medical term that's used. Incomplete spontaneous abortion is a miscarriage. So like we talked about earlier, where the baby just doesn't develop, but the miscarriage is not completed. Products of conception, which is the extracted placenta and remains of the fetus or the baby in the aftermath, but can feel really invalidating to read that about, what was left of your baby on paperwork. A D&C is often performed in a situation of an incomplete miscarriage, so dilation and curettage, which is performed during the first trimester, and a D&E, or a dilation and evacuation, is performed during the second trimester. So those might also be terms that would come up that a client could be confused on. Pregnancy after loss is another category of this. You should just expect that a client's going to be anxious about the pregnancy moving forward after this. That's anticipated and completely understandable. It's a complicated emotional experience, trying to hold the duality of joy and excitement with grief and fear. There can also be just a new wave of grief that comes, like wishing you could have both babies, wanting the previous baby instead, gender disappointment too, especially if first baby was one gender and second baby's another gender, can just be really tricky to navigate with a client. There can also be a lot more triggers that maybe in an initial pregnancy would not have been triggering. So mild spotting or cramping, any kind of milestones that you hit, like if someone lost a baby at 7 weeks, getting past that 7-week milestone might be really relieving, but it might also be really triggering for a client. Ultrasound appointments can go from being excited to check in on baby to being nervous that they're going to confirm a worst case fear again. Doctor's appointments and locations can also be a really triggering experience. If they, had the same room that they were in previously with a provider that they were with previously that they got bad news, and it's going to be really hard to go back and face that experience. So you want to really help client either build up courage to do so, or to switch providers, which we'll kind of talk about advocacy, self-advocacy, and choice making in a little bit. I like to kind of think through Dr. Tonkin's growing around grief. I don't know if y'all have heard of this metaphor about grief, but people often will tend to think like time heals all and grief shrinks over time. But in reality, our grief doesn't actually shrink. Our worlds just grow bigger around it. So we'll talk with that about mom. Like you are with mom, you're not going to necessarily one day wake up and be like, oh, that doesn't affect me anymore. But your world will expand and grow, and your experiences will expand and grow around that grief. It will always be a part of you. You'll always potentially feel tender to the grief around that, but you'll be able to cope better as your world grows bigger around that struggle. Oftentimes we can experience clients or moms who are struggling with a lot of guilt, shame, and self-blame. It's innate, instinctual, and can feel really physical. And you can see from the graphic there just some of the thought processes that can come up for moms in that period after losing a baby or losing an infant. It can come from a deeply wired and instinctual place, almost for a sense of control or reason in a situation that is really out of the individual's control and often has no specific reason. Anger and jealousy can often build up from, why do other people get to experience this? Or why am I seeing now that everyone is pregnant on social media? All of those things really come up because anger is a powerful and protective emotion, especially in an acute grief setting. It keeps you really from being in total just despair and depression over it all. So we want to not completely shoot down a client's anger or jealousy in those moments, but really validate and know that there's some real sadness, grief, and despair underneath that anxiety or underneath that anger. Oftentimes this is a really invisible and unspeakable loss for women, and for men too. I mean, for partners in this scenario, it can be extremely invisible because people might not even know, and their spouse wasn't showing any signs. So of course they're not going to be telling people yet. So it can be really hard for both partners to manage. The sufferer here has to share with outsiders, which can be really hard if they want their loss to be acknowledged. It's not something that necessarily will be organically known by others, especially if they hadn't made announcements yet. The loss must be shared in order to gain support, which can feel really, really scary. An individual, couple, or others might be uncomfortable discussing what went on. There's kind of a culture of silence around uncomfortable things, which we know, just in general as practitioners, but especially in a situation like this. The isolation of it is negative, but privacy can actually be a positive thing if that's desired by the individual, which often is not the case in a situation of a stillbirth or a termination for medical reasons that happens later on. At that point, women or couples may have already announced pregnancy, might already be showing, and so there really isn't any privacy around that topic. Some people might be better to disclose to than others, and in some instances it might be easier if the news isn't out there for everyone to know. So of course, just meeting the client where they are and that, and encouraging them to, as they feel comfortable, share that news, and as they feel the need for privacy, be able to keep that to themselves, especially if that helps them get through the day. So kind of, again, tapping into some of the isolation and invalidation that can occur. Oftentimes people will go to kind of self-protective responses whenever people try to share something about their grief in these situations. Others might feel so uncomfortable in this pain that they want to make it better, which we see in other scenarios too. This is not new news, but toxic positivity and cliches can be really leaned upon by others in these scenarios. Like, well, at least you were only 6 weeks along, or at least you can try again for another baby. At least you're still young and you've got plenty of time to build your family. Or, well, this baby just wasn't meant to be. God has, another plan, or it's all in God's timing, or everything happens for a reason. We don't want to go to any of those scenarios, especially, or any of those cliches, especially in our therapy setting. It really discourages the grieving person from sharing with others, and kind of gives them this impression that they should be looking on the bright side of something that's really, really dark. They do not need to be finding a silver lining around anything, especially in the immediacy of a loss. And this is really about, as we know, other people's inability to sit with the mother's grief. So it's vital as clinicians that we can sit in this grief and help manage our own discomfort without relying on these cliches. So in an actual therapeutic setting, we want to be sure that we're holding space, of course, for this client, just like we would any other client. We want to really mirror their language and pay attention to how they're referring to the loss. So examples of that could be, is this, is the mom referring to this as a baby or a fetus? Is the mom using a name for baby? Or we might even want to ask, was there a name? Do you feel comfortable sharing? Did you have a name in mind that would be helpful to speak out? So we want to mirror the client's language. We don't want to be calling this, a loss of a baby if they were having a chemical pregnancy and we're 5 weeks along and it doesn't really feel like it's impacting them that strongly. Just depends on the client. We want to ask versus tell. So, of course, you might have a lot of knowledge on this topic, or you might have your own personal experiences of this topic, or know someone who experienced this, or walked with another client through this. But just like in anything, we want to monitor our own self-disclosure. We want to ask client things. Do you feel comfortable sharing what happened? How did it feel in that moment for you? What does it feel like to talk about this now? Is this something that you've been able to talk with other people about? What does that bring up for you as we discuss that currently? And then we can transition into a space of, do you want to know what I know about that topic? Would that feel helpful to you currently? And then we, of course, want to meet the client where they are. I mean, you are treating a human in an extreme experience. So extreme responses are appropriate. Extreme reactions can be appropriate in this scenario. Extreme displays of grief, of sorrow, all of that. Of course, is clinically significant, but should be expected and anticipated in this scenario. We want to also be able to display our own containment. We want to show genuine empathy for them, but also contained. We don't want to be, especially if this is something that's triggering for you, We can't also be, a crying ball of mess on the ground while our client is also sobbing, but, feeling genuine empathy for them is also important as well. We want to help a client expand body and emotional awareness, of course, helping the client to identify emotions and sensations going on for them. And we want to make sure that we have some exercises that kind of can build in mind-body connection as well, especially if a client is feeling really disconnected from their own body or feeling that their body betrayed them or opposes them in a time like this. We also want to use language for trauma in this. It needs to be something that's tolerable for you as the therapist to help make it tolerable for the client. We have to be able to tolerate it to show that the client can tolerate this pain. And we have to know also that nothing that we say is going to make it better. That should not be our goal. That isn't our goal right now. So kind of thinking through the crisis planning of this, just like we talked about hierarchy of needs before in the perinatal period, we want to kind of think through a similar hierarchy of needs here again. Biological needs first, sleep, food, if they have other children, trying to arrange childcare and time off if they're working. In the immediacy of loss, we want life-sustaining measures first, eating, sleeping, hygiene, things like that. Social support, which people feel supportive to them and which ones don't. It's okay to set limits and say no to unsupportive people in this time period. We want to be able to identify and mitigate triggers, what might cause panic for that client, upset, re-traumatization, potentially going and sitting in a waiting room with a bunch of pregnant women in this time period while they're getting checked up on after a D&C might be something that's really triggering for them, or having to attend a sporting event with their older child who 4 of the moms have newborns after they've just experienced a stillbirth would be something that might be triggering and cause panic for them or re-traumatization. So trying to pull other resources, so maybe mom can call ahead and request that she sit in a separate room to wait for their practitioner to check on her instead of sitting in the general waiting room. Or maybe dad is the one who brings, or an aunt or grandparent brings kid to practice for a while so that mom doesn't have to sit or dad, either one doesn't have to sit and face that trigger in that moment of seeing all the other babies there. We want good information. We want trusted sources of information. A lot of people can be well-meaning and well-intentioned, but we want to be sure that the client has trusted resources around them. And then, of course, crisis resources too, online groups and hotlines, things like that. You can just expect a client is going to go in and out of crisis. They're going to be fine for 2 days and then devastated for a week and then fine for a week and then have 3 really low days because of something that triggered them. So you want to, of course, be aware of that and be cognizant of it and treat it as crisis without thinking, oh no, the client's backtracked. This is just a part of that, nonlinear grief cycle that we treat in other scenarios. Psychoeducation can be helpful, especially if a client feels like they're ready for it, or if you feel like a client is getting to a place where a more fact-based information could be helpful. Talking about the prevalence, the basic statistics we went through at the beginning of that can really help a client feel less isolated or alone, such as 1 in 4 women miscarry. It's unfortunately common, but that doesn't mean that it feels normal or okay, but that they aren't alone in this suffering. Sometimes talking through risk factors can be pretty helpful, especially if a mom is feeling a lot of self-blame. We want to ask kind of the question of, does this client match any risk factors? And we want to be careful with that because there are risk factors like obesity, advanced maternal age, things like that could potentially hit a more intensified self-blame spot. And we don't want, obviously, our clients to be blaming themselves more, but things like infection, hormonal imbalances, uterine abnormalities and birth defects, an incompetent cervix, where your cervix begins to open too early to pregnancy, autoimmune disorders, certain diseases, all of those things a client cannot help. There's nothing that they could do to change that. So it could be helpful to go over those risk factors to kind of alleviate some of the self-blame a client might be feeling. Potential next steps for medical intervention or for diagnosis and treatment. It's often really helpful to be able to answer any unanswered questions and kind of talk through prevention of future loss if that's possible. Oftentimes I feel like it will be a client comes in talking about something that was brought up as a next step in their meeting with their OB, and they're trying to get their mind wrapped around what their next steps could be. And it can be helpful to have a safe space to really divulge some of those thoughts and just process out loud for a mom, especially when they're just so overwhelmed in that stage. The expected emotional response, like we said earlier, we're treating a client in an extreme situation. It is expected that they are going to have potentially an extreme emotional response to this. So that's okay. It's also, we can sometimes point out, like, you might have a temptation to blame yourself. It's not your fault. It's no one's fault. You didn't do or anything that would cause this. The grief and healing process, just really validating for a client, whatever their grief process is, it's okay and normal and valid. Oftentimes I will have clients who can come in and say, like, well, I just don't understand. This is hitting me so hard. And like, I know someone who had a stillbirth and it didn't seem to affect them the way that my miscarriage is affecting me. Really normalizing, like, you don't know the inner workings of how that actually impacted that person, or if they're really even addressing the impacts of that trauma. And we also don't need to have comparative suffering or comparative grief here. We can just accept how we're feeling in this moment, and not feel the need to make a hierarchy of people's grief or pain. And then, of course, going through, mental health treatment options, which if they're already in your care, you shouldn't have to necessarily go over because they're already seeking that out. So choice advocacy. Choice increases a sense of agency, which in turn decreases the feelings of helplessness and prevents further trauma. So we want to help client work through best choices for them in any of these situations. Medical management in a miscarriage, the options are generally expectant management, which is just kind of waiting for the body to recognize and that it's no longer pregnant and expel the products of conception, that term we talked about earlier, on its own, which can be very traumatic, and especially to do at home. But sometimes clients feel like they need that experience to really put kind of an end cap or come to closure around this. There's also medication, which Cytotec, which is from abortion protocol, but it's honestly most likely not an option in Texas right now. So that's not really something that I don't know, unless an OB has offered that, spend much time on. Generally, the other option that's given is a procedure or surgical delivery. So that D&C or D&E that we talked about earlier, which can be beneficial because it's under anesthesia. The client's not really aware of what's going on. That might be helpful for some clients and hurtful for others. There is also kind of the pain and anxiety management. Oftentimes it can be helpful to help a client in session draft up a message to their OB to ask for, pain meds. Of course, if this client has a history with addiction, that's something that you'll want to, mitigate risks for there. But to ask for things like pain meds or anxiety meds, if they're not currently on them, oftentimes it can feel really intimidating, or just you're not in the headspace, or a client's not in the headspace to ask for and advocate for themselves like that. So it can be helpful to draft up a message in advance, or even help them send an email to their provider. If past the 16 or 17 week mark, a mother will actually have lactation that will occur even if there's a loss. So you really need lactation support for bereaved mothers. It's super important. They can, oftentimes OBs will offer medication in order to, or take medical measures in order to make the lactation stop. But some moms might want to pump and donate their milk in order to honor their baby. So again, just choice advocacy, what feels best for them in that scenario. Genetic testing is often an option that clients aren't necessarily aware of unless they've had multiple losses. So this can help to really know what the options are here to advocate for yourself. So like Anora genetic testing, I know, is one of them. They can be helpful to know if, there was a genetic abnormality or something that went wrong with baby genetically. Switching providers is often something that clients don't really feel like they have the permission to do in the aftermath of a loss, but discuss that it's okay to do that if the client feels that that's necessary, based on either how the clinician handled the situation, or just if there's trauma in their office and a client does not want to have to sit in that office again. That's understandable too, and a perfectly okay reason. And you can help a client find a provider that would be really good for them. Just a little self-disclosure here. Some of the things that I had to advocate for myself for in the aftermath of a loss was not sitting in the waiting room after I found out there wasn't a heartbeat anymore on the ultrasound. They were sending me out into the waiting room, and I had to stop and say, no, I would like to not sit in the waiting room. I would like to sit in a separate room. So even just helping clients build up the courage and things like that, or know that that's an option if this comes around. I also had to request genetic testing afterwards. That was not offered to me. And then in the infertility journey, which is a whole other discussion, I had to do a lot of work to request and self-advocate for blood work, testing, imaging procedures, etc. So that can be something, especially if you're on a journey with a client who's had recurrent loss or is struggling with infertility, to know like, hey, let's sit down and look through some options of other ways that this can be approached. Because oftentimes practitioners just have their preferred approach, not because they're trying to be cruel or not give a client options, but just because that's how they do things. But oftentimes they don't mind if a client asks for something different. They're happy to oblige. And then in the infertility journey, oftentimes infertility clinics just kind of have their next step, and you're can just kind of be sent down their line of first responses. And oftentimes you have to really ask for things that you want in either of those scenarios. So we also want to, once a client feels ready, offer gentle challenges, but only after the therapeutic relationship is formed and after the client is stabilized and out of crisis. Again, we want to think hierarchy of needs first and then move on to gentle challenges once a client is in a more stable place. We want to challenge cognitive distortions and harmful thoughts and provide gentle confrontation that can propel a client towards the next phase of change for them. So a lot of times, examples of this can be, like a client might come in with this cognitive distortion or harmful belief of, what if my anxiety made me miscarry? Or what if the run I went on, I've heard that before the client, what if they were training for something and they had been a runner beforehand, but like, what if this intensive run I went on is what made me miscarry? Or what if I ate something that I shouldn't have that made me miscarry? And then, going into more existential or spiritual places of, what if God's punishing me for this thing I did in the past? Or maybe I'm not cut out to be a mother. We want to give, some kind of pushback on that. Like, some of my favorite questions are like, what do you think I would say or think about that? Does that match what other people in your life believe about you? Is there something else that could also be true in that scenario? Or can both things be true at once, right? And then moving on to kind of meaning making in this situation. This is kind of the 6th stage of grief after what the client's experienced. It's not everything happens for a reason. It's not this was meant to be, but it's more post-traumatic growth, a life-changing shift and the way that they think about this experience. Potential outcomes of this can be personal growth, strengthened familial and friendship bonds, a shift in perspective, enhanced gratitude, lifestyle changes, spiritual growth, a new sense of purpose, or even philanthropy or advocacy work in the aftermath too. But again, this is after, you're far down the line working with a client. Some forms of active healing that you can assist a client with would be things like, do they want a funeral for their baby? And that doesn't have to mean that you have the remains with you, right? Like, we can bury something in their honor in the backyard. Or I had someone I know actually take the remains of the baby and they planted them underneath a tree. And that tree was in their, forever home backyard. And they felt just really safe and comfortable around that tree. And just was a constant provider for them, or a constant reminder for them. Some kind of memorial that they do, maybe one time, or is that yearly on an anniversary date of, baby's loss or due date, or the day that they found out that they had conceived. Sharing information with others can also be really helpful, especially if a client feels ready to. Photographs or pictures of baby and kind of memorializing those in some way. Anniversary dates, like we said. And then in the therapeutic setting, if you have the ability to, and the training in EMDR processing can be really, really helpful around this. There is also, there really is a need for us to grieve physically too, and to do these physical things or these active things in order to promote healing and begin the meaning making process. So things like a name, funeral, like we said, even deciding what your verbiage is going to be around this loss. Is that something that the client would just rather not speak about when they're talking about the number of children they have? Or is that something that they want to use the wording of, like, I have one child in heaven, or I have a child no longer living? That's something that you can kind of go through and really process through in session. Potentially spreading the ashes or doing something like cremation jewelry can be helpful. Especially if it's a stillbirth and, they experienced holding the baby and things like that. We want to create actions to honor this grief in order to be able to really healthily move through it. And kind of lastly, I want to remind you that you are in the room too. This is a really, really triggering subject for anyone, but especially if you've experienced this yourself, or if this is just a really tender spot for you, it's totally understandable. it can really trigger your own fears of the world in worst case scenarios. So we want to monitor activation of countertransference. We want to be able to know our own limits and know it's okay to turn away a client if you don't feel like if you feel like this is just too much for you. Feelings of inadequacy are really, really normal in this experience. I mean, there's nothing that you can do or say to make it right or better. There's no acute thing that you can apply treatment wise that's going to fix this for the client. So yeah, it's really normal to feel inadequate. Your job is not to solve or fix anything for the client. Your goal is to walk with them through this rather than have them do it alone. So remember to care for yourself as you care for your clients, just like we do in any scenario, but especially here. So kind of some final resources. PSI, Postpartum Support International, has an amazing website. They have free support groups of all type. And when I say all types, like everything from, perinatal loss, obviously stillbirth, down to like Black mothers who are experiencing infertility, right? Like it gets very, very specific. And their groups are free. They're often online and encompass people all around the United States and the world. So awesome resource to look through, especially if a mom is in need of some kind of support group. They also have a list of providers that you can put in your area. And they'll be providers who are on the PSI registry that can be OBs, doulas, clinicians, like LPCs or social workers that can be really, really helpful to know, especially if your client's wanting to switch providers. Some additional resources. I haven't interacted with all these resources personally, so I can't necessarily endorse them fully, but just wanted to provide those for you. It's a lot of books and things that could be helpful for you to look through. So just something to look into yourself. And then my sources for this, as well as just some more information about our group practice, Rise Wellness Group. We're in Houston. We're a really kind of all-encompassing general group practice. I think we've got about 8 to 10 clinicians right now. I'm not exactly sure of that number. I don't know why that number never sticks for me. But we're an awesome group of LPCs, LPC supervisors, as well as interns and students. So yeah, check us out. And if at any point y'all are needing additional brown bag presentations, I would love to come back if I'm able to and talk about kind of reparenting the self through the parenting journey, because I love working with parents as well as, in the perinatal phase. So yeah, would love to discuss supporting parents as they parent through their own pain and process of reparenting themselves. So yeah, just something to think about for the future if y'all are needing another presenter. Thank y'all so much for letting me talk today. I think I hit it right on the hour mark. Awesome. I would love, I'm here and available for a few more minutes for questions if y'all have any. And if you'd rather not share a question or a personal story or something, you're welcome to email me. My email is listed on there. So please reach out. That's all.
Paige, thank you. We've got comments people saying thank you and that they loved it and they really appreciated it. The presentation that you provided, I sent that link so that they can download that.
Good.
So people may follow up with you. And of course, anybody that's watching, if you can't find the presentation or you have any questions, email me and I'll help you figure that out and get you in touch with Paige if you have more information or questions for her.
Awesome. Yeah. Thank y'all so much.
Thank you.
It was so definitely. Good. Very helpful. Thank you. Good. I'm glad it's helpful. I mean, I wanted to share something that would feel helpful to y'all and relate to the clients that y'all see. So I'm glad that it felt beneficial for y'all.
Yeah.
And I'm glad you're out there doing this work. So thankful because this, I think, has been so overlooked for so
Absolutely.
long. So thank you for the work you're doing.
Yes, absolutely. Thank you for that encouragement.